Hey, Viva Lifers, this is Dr. Kelly. I am a board certified OBGYN as well as a healthcare executive. And we have you here, and we're excited to have here Dr. Leah Brown, who is an orthopedic surgeon. She is going to explain to us exactly what she does, how she got to where she is, and tell us about, what are some of the healthcare disparities that she's seeing in orthopedics that you need to know about. So with that being said, Dr. Leah, you're on.
Hello, everyone. Hello, Viva Lifers. I'm Leah Brown. I'm an orthopedic surgeon. I specialize in this surgery, the sports injuries typically. And so a lot of times people aren't sure what an orthopedic surgeon does. But I'm not specifically a foot doctor. There is a foot specialty within orthopedics, but so I'm a surgeon. I do trauma. I do everything from fractures to ligament injuries, tendon repairs, arthroscopic surgeries, and regenerative medicine. I take care of athletes from the range of the weekend warrior to the professional athlete, and essentially anyone that is using their body as what we will consider an athlete in their own right. So my job is to make people functional. I don't typically deal with a lot of sick people. I deal with people who are injured and people who are looking to improve their function. I am board certified, which means I have gone through undergraduate medical school, orthopedic surgery residency, which is anywhere from 5 to 6 years, and then an additional specialty training, which is another year. So they make sure that we're nice and old and gray before we get all of the letters behind our name.
Absolutely. My goodness, it's just so much. So one of the things that I've told everybody about is the fact that you're also a veteran. So although you are not representing the United States Navy as you are representing yourself here, tell us about what it's like being an orthopedic surgeon in the military.
So what's very interesting is that, the military is a microcosm of our society. But you can imagine that the people who are in the military are typically on the healthier side. And most of a lot of times they are injured more than they're sick. They certainly get sick and they do kind of regular people things. But, injuries are a big part of medical readiness in keeping our men and women of the armed forces ready to do their job. So that's a lot. Like, we are a very, very busy service in military medicine as far as orthopedics, and our Marine sailors and soldiers and airmen injure themselves very easily with all the training and all the high intensity activities that they engage in.
So thank you so much for that, because I don't think a lot of people understand that medical readiness doesn't actually only have to be in the military, which you have had excellent experience there, but it's also in our communities. So when we think about community readiness, we also think about, okay, what are some of the healthcare disparities that you're seeing in the community, especially in regards to women and their healthcare as an orthopedic surgeon?
So I think it's really important for people to understand that, when you are not high functioning, it affects all aspects of your life. And as productive members of society, we've got to be able to do all of the things that are asked of us. And especially as women that are really holding up, the hard parts of society, we've got to be at our best. We've got to function in both in the home, in the workplace, kind of all those aspects. And when you're injured, when you have knee pain, shoulder pain, back pain, all of these things that are inhibiting your highest productivity, it is important to address it and make it better. And we have interventions and therapies to address that. And I think what's really important is that so many times women, like, we can be our own worst enemy. So there are disparities on both sides, right? So there are disparities that come from medical institutions. A lot of times, research and things that are studied are based on a certain demographic that often doesn't involve people that look like us, but also part of kind of the sociocultural parts of our society is that women don't prioritize themselves and their health. They prioritize everyone else first. And by the time they are actually reaching out for help, things are bad, their function is bad, their mental health is bad because their function is bad. And, it's important for them to find medical providers that understand this. as we get older, of course, the body wears out like a machine, like everything else. And so it's not going to operate the same way at the age of 45 as it did when we were 20. And so it is important to understand those dynamic changes. And one of the things that we really try to address with minorities and women in orthopedics is the offering of all of the treatment options and not just, certain treatment options. I think as a culture, we are kind of suspicious because people haven't taken our complaints and our issues seriously, that, maybe they're offering me surgery because they're trying to, do these things that they're experimenting on. But if we look at the research, it's actually the opposite. It's more that we are not offered some of these high technology, these interventions that can get you back to a higher functional level earlier, better. And so we're not getting offered the knee replacements, the hip replacements, the arthroscopy surgeries, the rotator cuff repairs, in the same way that maybe other demographics are, where it's like, oh, you're anxious, or maybe you need to lose weight, or maybe you need to deal with all these other issues. And you're like, no, I have a rotator cuff tear. It needs to be repaired. No, you know what? I have knee arthritis. I can't walk 2 blocks. I've gained weight because I can't exercise. How about a knee replacement? And, so these are the conversations that I'm trying to have and trying to engage with our community, that intervention means a lot of different things. And I think it's important for you to find the right type of provider that's going to address those things. And it's not always the thing that you may want to hear, but it's finding the person that you trust to tell you the things that you need to hear.
So that is just so important, because I think a lot of people don't get offered a lot of things, right? It's one of those things, like, you can't get through the gatekeeper, and the gatekeeper typically is our primary care. And shouts out to all the primary care doctors, because we know you see thousands of people and your clinics are very busy. So it's sometimes very difficult to figure out, okay, who does and who doesn't. So what are some of the things, when you think about the top 3 things that you are doing surgery on, what are those top 3 diagnoses? And choose one of those, as far as what do people need to come to you with in order to set themselves up for success for the orthopedic surgeon?
So I think that it is really important, for instance, shoulder pain. Shoulder pain is kind of the textbook easy example. So, shoulder pain can affect men and women in a little bit of a different presentation, and the way women and men communicate are different. So if someone has shoulder pain, whether there was an injury or not an injury, right? I always need x-rays. And what's very interesting is sometimes the backlash we will get from patients who are like, no, I know that it's not fractured. I need an MRI. Well, x-rays really show us a lot of things first. And an MRI may not be the next best imaging modality or treatment modality that I need, because if you have advanced arthritis, MRI is not going to show me anything. Like, I need some other things to help me with that plan. I need to look at alignment. I need to look at bone quality. I need to look to see if your shoulder pain is actually a musculoskeletal issue, or if it's metastatic cancer, or if it's osteoporosis, or if it's all of these other things that can cause musculoskeletal pain. What I will tell you is that musculoskeletal pain is painful. Bone pain hurts. Cartilage pain doesn't hurt as much, okay? But bone pain does. And so we need to look at the bone and all the modalities that really show us bone pathology. So I need an x-ray. If you're coming to me without an x-ray, I'm going to order an x-ray. If you don't want an x-ray, then you need to find another doctor, because that means you are not getting the optimal care that you need for me to make appropriate treatment decisions. MRIs, sometimes patients almost feel like they think they're therapeutic, but MRIs are diagnostic tools to help us confirm diagnostic suspicions that we have. And sometimes that's not the best thing. Sometimes we need bone scans. Sometimes we need CT scans. So coming to an orthopedic surgeon without an x-ray is the biggest red flag ever. So if you have a musculoskeletal complaint, the first imaging modality that you need is an x-ray to make sure that we are dealing with the right pathology.
That is so, thank you so much, because even as an OBGYN, people are like, well, I need an MRI. And I'm like, really, I don't think you do, but every orthopedic surgeon I talk to needs imaging. Like, a x-ray at least. And there's different views, right? There's a front view, the side view, the middle view, whatever.
Right. And I need all the views.
We need all the views, right? So that's so important. And then what should people expect? Okay, so say like you see something is wrong, you find something wrong on x-ray. How do people know that you're offering them the right surgery and you're just not trying to take their money or, put them under surgery for just because you're a surgeon and you want to operate?
So that's one of the things that I spend a lot of extra time with patients. And so one of the things that I think is important for patients to understand is that just as frustrated, they are frustrated with our medical system and our healthcare system weaknesses, physicians are frustrated as well, because we got into this to take care of people. I want to take care of people. I don't want to operate on people that I don't think I can make better. Patients really need to understand that that is not a good thing, right? So, having that discussion and making sure the patient feels that they are a part of this treatment plan. We are a team, right? So I need to hear from them. They need to hear from me. If it's not going to work, it's not going to work. This is like a relationship, right? So if I am going to cut on you, you need to trust me that I am going to do the right thing, but I also need to trust you that you trust me to do the right thing, because if it's a conflict, no one wants to start a relationship like that. So the first part is open communication. Have I addressed all of your questions? Do you have any other concerns? Like really, and it can be basic, like, do you trust that I'm going to take care of you? Or have you had a bad experience? Do you feel heard? Are there other things that I need to take into consideration? Can you afford the physical therapy that is going to be required after that? Because if you can't, then we need to talk about other treatment plans. Can you actually be non-weight bearing on this extremity? Do you have to walk to the bus stop every day? Can you do the things that are required to maximize your outcome? Because if you can't, then we need to engage in better conversation so we can optimize your outcome, because all I care about is that you're better. It's not about doing surgeries. It's about you being better. And having a patient that's not better coming into my clinic saying, I'm not better, nobody is happy that way. So, I need to know all the things. Hey, I don't really have adequate help at home. Hey, this is my dominant arm and I live by myself. So I'm not going to be able to really take care of myself. Okay, well, then maybe we need to talk about something else, or maybe we should try this, this, and this, or maybe we do home health, or maybe we do this, or maybe I use this different treatment plan. But that kind of communication with your surgeon is needed to optimize outcome. And I think especially in our communities, that's so important, because we span the demographic when it comes to access, resources, socioeconomic issues. Like all of those are important in considering how to best treat a situation to optimize their outcome. I can't operate. I don't want to operate on a person and I say, you know what, you can't work for 3 months. And they're like, well, then my kids don't eat.
So you are like dropping gems and jewels and all of that, because a lot of people don't think about the social side of having healthcare, surgery, the post-operative road back to health, because there's going to be a road back to health. So thank you so much, because so many people don't talk about those parts of it. Dr. Brown, I first want to say thank you so much for being with us for the last 10 years. The last 10 years, every single time we asked, you are always there. We've had a series on menopause and perimenopause. We've had a mental health physician, psychiatrist on, and we've had an OBGYN that specifically manages hormones in perimenopausal and postmenopausal women. So from an orthopedic surgeon standpoint, what are some differences you see in perimenopausal or postmenopausal women that we need to be aware of?
I think what we need to, as a medical community and as a society, understand the physiologic changes involved in aging, period. And women, men deal with it too. I think as a society, as with most things, science and leadership and whatnot addresses men's problems, which is why they have, more advances in sexual health and ages and, these new diagnoses of low T and hormone replacement. It's the same thing with women, right? So as our bodies change and our hormones change, our responses to healing change. So, we're susceptible to osteoporosis. We have different kinds of tendon injuries. We have different manifestations of joint pain. So estrogen is almost euphoric. And when you don't have estrogen, things hurt. We call it the arthritis of menopause. So joints hurt, you get stiff, you think, it just hurts. People get frozen shoulder more frequently. You have all of these issues. And when I start listening to a lot of my middle-aged women who are like, my shoulder hurts, I'm falling apart, my knee hurts, my heel hurts, my back hurts, this hurts. And I'm like, by chance, are we going through menopause? Because, maybe are you a good candidate for like appropriate, that's the right thing, appropriate hormone replacement therapy, because all hormone replacement therapy isn't great and safe, but some hormone replacement therapy is fantastic for the entire body system. And this also includes like insufficiency. We call them insufficiency fractures. So women obviously are more susceptible to osteoporosis. So the thinning of bones, because we don't produce estrogen. Men, in fact, produce more estrogen and, postmenopausally than women do. And so it's protective to their bones. And so that's why, you step off of a curb the wrong way and all of a sudden you have a tibial plateau fracture, or you fall in a way that never bothered you before and you have this proximal humerus fracture and you're like, what the heck is going on? Our bones are softer and there are different repercussions to that. So vitamin D and, taking calcium and making sure that your thyroid is functioning appropriately, not just doing it because taking thyroid hormone feels good, but, appropriate hormonal function is important for bone health. Because then, like when we're talking about doing a rotator cuff repair in someone that's osteoporotic, if I touch the bone, like when in some middle-aged, in some women who are truly osteoporotic, I literally will put my finger on their bone and I can mash it through. That's how important it is for us to make sure that our bone health is important. We've got to be able to engage in that impact activity, the jumping, the things that are going to increase our body's ability to increase your bone health.
You have said so much there. The thought that you could literally like touch their bone, and it could fracture and come apart, that's scary. And thank you, SW, for asking about insufficiency fractures, because that's a word I've never heard of. As you know, as an OBGYN, we talk about, hormone replacement therapy and getting your bone scan and bone density scans and all that other stuff. But after that, I'm out. I'm out. I got to send you to somebody else to help with that. So that's a, great point in regard to that. And on tonight, I think that's one of the reasons why Dr. Brown and I work so well together, because as an OBGYN, I'm really a primary care person as well. But then also with the Viva Life Health Hub, we are trying to bring in these experts that can help you so that you are proactive and not reactive. So I believe in the link that she probably sent you, you can see the link tree. That's what we're all about. We're about changing the mindset so we can change the outlook, changing how we're managing what we're doing as far as our nutrition, our exercise, and then also making sure that, spiritually, mentally, and emotionally, we're in the right frame of mind. So really great. So Dr. Leah, can you do us a favor and let us know how we can get in touch with you online, social media platforms, whatever it is that you have for us?
So I can be found at leahbrownmd.com. That is my personal website. I've got great educational videos. I've got a contact me information. I have my own practice. I have both an urgently ortho practice, and I am now part of this brand new state-of-the-art sports medicine and performance center at Banner Health and the University of Arizona. So I'm teaching. So I'm in a lot of different places, and you can find me on Instagram at Dr. Leah_orthodoc. You can find me at Facebook at Leah Brown MD. So reach out. I will give you all the little tidbits. And women's musculoskeletal health is a big thing, and we are making that our priority in 2023.
Awesome. Thank you so much. Thank you, everybody, for coming on. Ask Dr. Kelly OMD. You can find me at drkellyomd.com, DRKELLYO. Please let your friends know about this. We definitely want to make sure that people understand that we are here for them and we are bringing them top-notch experts that look like them or maybe don't look like them, but they're the best of the best, and only the best of the best come through Viva Life. So have a wonderful evening, and don't forget to do what? Viva Life. All right. Thank you for being a part of the Viva Life experience. I'm Dr. Kelly MD, board certified OBGYN and healthcare executive. If you like what you heard, then please go ahead and like, share, and subscribe. The reason why is because we are trying to educate, encourage, and inspire 1 million people to live their healthiest and wealthiest life. And this is what we're bringing you. We're bringing you educational videos. We're bringing you podcasts. We are bringing you webinars with subject matter experts, including myself, about the topics that affect you the most. So go ahead, like, subscribe, and share. We are everywhere. Have a wonderful day. Viva Life.